Hello, my name is Lindsay Hessler, and I will be presenting our work entitled Anti-Reflux Surgery Leads to Durable Improvement in LPR Symptoms on behalf of my colleagues at the University of Wisconsin. Thank you for having me. First and foremost, I have no disclosures. I'll start with a brief background. As you all know, GERD is a very common problem affecting over 20% of the US population. Symptoms are classically thought of as typical, meaning heartburn and regurgitation, or atypical, including cough, globus, and other laryngopharyngeal symptoms. Previous research has shown that typical symptoms respond predictably well to anti-reflux surgery, whereas the existing data suggests that atypical symptoms have a less reliable and more variable response to surgery. In light of this controversy, we aimed to analyze the overall response of LPR symptoms to anti-reflux surgery in our patient population, as well as to characterize the response of individual symptoms to surgery. We performed a retrospective review of prospectively collected data at our institution. IRB approval was obtained for this study. UW prospectively maintains a database of all foregut patients. We searched for patients undergoing Nissen and Toupet fundoplication between 2008 and 2020. Patient-reported data is collected via questionnaire and entered into the database. Questionnaires consist of items from previously validated scoring systems, including both the GERD HRQL and Reflux Symptom Index, or RSI. They are conducted at specific time points, preoperatively, and 2, 8 weeks, and 1 year postoperatively. Additional patient demographic data was obtained via chart review. Here is a list of questions that comprise the RSI, previously published by Belaski and colleagues. It is a validated scoring system that provides a measure of patient-reported LPR symptoms. Each question is rated from 0 to 5, with a maximum score of 45. Their study suggests that an RSI over 13 is abnormal. 1,809 patients were in our database during the study period. Patients were excluded if no RSI data was available or surgery was scheduled after March of this year, allowing for at least an 8-week follow-up. Patients with more than one missing RSI answer were excluded, as well as those with door fundoplication, type 4 hiatal hernia, achalasia, or those who did not undergo surgery. The final cohort consisted of 176 patients. For analysis, patients were grouped into normal and abnormal based on the published cutoff of an RSI of greater than 13 as abnormal. They were compared using a t-test and chi-squared. Our RSI score analysis consisted of multiple parts. We created a box plot to visualize the change in RSI scores based on preoperative RSI, which we will review shortly. We also completed a multiple linear regression analysis to identify any factors that might predict an improvement in RSI score from preoperative to 8 weeks postoperatively. Factors analyzed included age, gender, BMI, esophageal motility, GERD HRQL score, and RSI score. The baseline characteristics of our patient population are listed here. The mean age was 57. The group was mostly female and had a BMI below 30. When comparing patients with a normal pre-op RSI to those with an abnormal RSI, we found a few differences. Patients with abnormal pre-op RSIs were more likely to be female, have higher GERD HRQL scores, and they were less likely to use PPIs and less likely to have normal esophageal motility. This is a graph of the mean RSI over time for our entire cohort. As you can see, the mean starts at about 19 preoperatively and drops to below normal or below 13 by 2 weeks and remains normal out to 1 year. These are graphs of individual LPR symptoms grouped by their response to surgery. On screen left, the greatest improvement is seen with heartburn, choking episodes, and hoarseness. Cough and difficulty swallowing had a moderate response, and symptoms like globus, throat clearing, and mucus or postnasal drip responded slightly less well. As previously mentioned, we prepared a box plot of our data in which the RSI score change was calculated between the 8-week and pre-op visit with a more negative score change indicating a greater improvement in LPR symptoms. The greater the pre-op RSI score, which is on the x-axis, the greater change in the RSI postoperatively. Here are the results of our linear regression. Age, gender, BMI, motility, and GERD-HRQL were not predictive of RSI improvement. However, having an RSI of 15 to 30 or greater than 30 were both predictive of RSI improvement. Compared to the group with an RSI of 0 to 15, those with a pre-op RSI 15 to 30 had 10 more points of improvement in RSI at their second postoperative visit, and those with a pre-op RSI greater than 30 had 16.5 more points of improvement in RSI. Here is a summary of our results. Patients with an abnormal pre-op RSI were more likely to be female and have a higher GERD-HRQL score. They were less likely to use PPIs or have normal esophageal motility. The mean RSI for our cohort improved to normal by 2 weeks and remained normal at 1 year. Heartburn, choking episodes, and hoarseness were the LPR symptoms most likely to improve postoperatively. And patients with worse symptoms, meaning an RSI greater than 30, had the greatest response to surgery. Also, RSI scores, higher RSI scores were predictive of an improvement in RSI based on our linear regression analysis. We did have some limitations. Our population was quite heterogeneous, many with both hiatal hernias and typical symptoms, so we were not able to totally focus on atypical symptoms. We have limited data on our long-term follow-up, but are actively accruing patients and hope to improve this. Lastly, the workup was variable for our patients. We had hoped to analyze impedance data, but unfortunately this was not available for all of our patients. In conclusion, we found in our study that patients with LPR symptoms can achieve a rapid and durable response to surgery. Heartburn, choking, and hoarseness were more likely to improve than other more proximal LPR symptoms like postnasal drip. And patients with more severe LPR symptoms experience a greater improvement postoperatively. We believe this information might be helpful in counseling and that anti-reflux surgery should be considered in this patient population with LPR symptoms. Thank you.